view on would be awesome. Cool. So hi, everyone. Heather Hammerstedt, emergency medicine here in Boise, Idaho. I work with Vituity. We've been moderating these panels since, I don't know, mid-March, KK, do you think? And it's just our way of trying to get some information out there for everybody about what's happening in various parts of the country, learning clinically from each other, trying to figure out, as we'll talk about today, some research priorities. And things change, as we know, like day by day. And so just trying to get, support each other emotionally, support each other academically, trying to figure out a way that we can try to understand what's coming to us or what's going to happen in the next wave and what happens in rural areas and in the cities. And so thank you for joining us. We have a great panel here today. KK is going to be monitoring the comments for us, and she'll drop stuff into chat if we need to talk some more so I can concentrate a little bit. And I'm just a curious person, so I'm just going to ask lots and lots of questions. First, I just want everyone to be able to introduce themselves, and then we'll get after some things we're planning on talking about today, which is clinical changes or things that we're seeing that have been helpful, anything logistically that people want to share that has been working or not working. We're going to talk ventilation strategy, hopefully with Hartwell, put him on the spot. And then we're going to talk about what it is like in a more rural area that is as hard hit prevalence-wise as New York City. So why don't we start first, KK, can you just say hello? You're on mute. There you go.
Hi, guys. Thank you so much, all of you, for coming. This is going to be phenomenal, just like the last one was with most of you guys.
Thanks. Caleb, you want to introduce yourself and say hello?
Sure. Thank you. I'm Caleb Hernandez. I'm ER board certified doc. I'm helping out at Coney Island Hospital. So I'm part of the emergency relief effort there.
Thank you. Mike?
Hey there, I'm Mike Wilson. I'm a community emergency physician from Texas, but I'm in New York City trying to help out as well with the relief effort. I'm the medical director of a 500-bed field hospital that we're running here, and happy to be here, and got some unique perspectives, I think. I can't talk, I'm tired, so anyway, happy to be here.
Thank you. Hartwell.
Hey everyone, I'm Hartwell Lin. I'm an ER doctor from California, also in Heather's group Vituity. I'm also here in New York, been here since Friday, helping out at Coney Island. Since then, I've been pretending to be an intensivist upstairs.
Thanks for that. And Tom?
Hi, thanks for inviting me, Heather and KK. My name is Tom Sugarman. There we go. Sorry, my name is Tom Sugarman. I'm a community ER doc in the San Francisco Bay Area, about 40 miles east of San Francisco. And I've been fortunate enough to go with Vituity to do a relief mission to New York, both to help provide relief to the physicians, take care of patients, and of course, we're trying to bring back knowledge to California because we're expecting there'll be some more outbreaks in California going forward.
Yeah. Thank you. Brock?
Sorry, I was muted. My name's Brock Bemis. I'm a ER doc at St. Luke's Wood River in Ketchum, Idaho. A rural area, kind of right in the middle of Idaho, that got hit pretty hard initially with coronavirus. Our prevalence rates were, some of the highest in the nation, and I got it pretty early as well. And now we are actually looking a lot better and in a situation where we're downstaffing nurses and sending some people home. So more of a, I think, from a limited resource and network kind of solutions perspective.
Yeah, and Brock, I know you and I both have night shifts tonight, and yours starts very soon. So I would like to start talking with you, if that's okay with everyone else, so we can get his perspective and release him to the wolves, so to speak. So tell us a little bit, Brock, about why, I'm, Idaho ASAP with you, and so we've been following along and trying to support from the sidelines, but we're 2.5 hours away, and you guys actually really like shut down kind of the borders of your county quickly, which was awesome. And we very much appreciate you guys for that, because Boise is much better off for it. But can you tell us a little bit about why you guys in the middle central Idaho, why you guys got hit so hard, and when that happened and what that looked like at first, when I think kind of taken by surprise by it?
Yeah, so honestly, you know, the area in which I live is it's a ski resort, and especially in February, it's kind of one of our busiest times. And our kind of, you know, the cities that have direct flights here are San Francisco, LA, Seattle, Denver, Chicago. And so we have a ton of traffic from Seattle, probably more than the other places. And as you guys know, they were definitely on the kind of front end of that wave. And we also kind of, it's a, you know, people are here to relax and party a little bit, basically. And so the bars and the concerts and even sitting on the chairlift, you know, turning and talking to each other, it just really, I think, set up an opportunity for the virus to spread. And it's also a really healthy population. And so I think that, honestly, in retrospect, we probably had a bunch of disease that we just weren't, you know, identifying very early. And it enabled kind of carriers to probably go into some of these public, you know, concerts, et cetera, and just rapidly spread throughout the people here. And unfortunately, you know, a lot of our visitors got it and took it home. But pretty quickly, it went from us not really thinking much about it to a quarter of our hospital being on quarantine or sick. And so we had to shut down the entire inpatient unit, mother, baby, surgery, all of our clinics. Basically, we were just a standalone ER with like a less, like an urgent, you know, an urgent care walk-in COVID clinic and a tent. And that was it for the whole valley. There was nothing else, basically. And that was pretty scary for a little while. And luckily, you know, we're part of a bigger network. And we actually send patients to Heather's hospital as well. And so we're really lucky that we were kind of able to just kind of triage and send people out. Luckily, the weather has been relatively good this spring, so we've been able to fly a lot of people. But we also set up a rotating ground crew situation where we had 5 different ground crews that would just basically do laps. The nearest referral hospital is 75 miles. And so we have some pretty big barriers to getting people where they need to be. And Boise, which is where a lot of the critical service, you know, the kind of really specialized and critical care services are, is, you know, 2.5 hours. So for a while, we were basically just rapidly kind of triaging people and hoping the weather was good and kind of getting them down, you know, to Twin Falls or Boise as quickly as possible. Now, you know, anecdotally, I feel like we're still seeing a large percentage of COVID cases that are coming into the ER, but I would say our volume overall is down quite a bit. And we're able to kind of, we were doing short shifts for ourselves too, because we were just getting so smoked. And now we're back to doing 12s, which is our baseline. And then, like I was saying before, we're sending nurses home. We're downstaffing nurses probably almost every day now.
And of your group of docs, like how many of you got sick, and why do you think that happened?
There are 3 of us out of 7 that got sick. And, you know, along those lines, we're actually super lucky to be in a system in which people from Boise and Twin Falls could come up and cover us, because we wouldn't have been able to stay open otherwise.
Yeah.
And I don't know, I mean, we socialize together because it's a small community. And so it may be that we picked it up socially, but, you know, again, I think that in retrospect, there were probably quite a few patients that came through that it was before it was on anybody's radar. And so I think that we certainly could have gotten it at work too. There was one patient that coded right at shift change. And so everybody, I mean, like 20 or 25 people got taken out by that one code, because it was before people were really wearing PPE or anything like that. And it was in the
everyone like rushed in like we usually do in normal life. Yeah.
And it was in the CT scanner, so it was kind of like people came from everywhere, and it was a mess. So that took out a huge chunk of our group, basically, and nurses too.
Can you tell us a little bit about the decision making around when you're going to fly somebody who's that critically ill and you're trying to decide intubation versus not intubation in the COVID era? I mean, I know you guys fly us people all the time, but this is different. So can you think of a case that you could make generic for us about kind of how that was a difficult decision and how you guys kind of protocolize that?
Yeah, I would say, you know, especially after I watched the recorded version of your guys' last talk, and people were talking about how long they're waiting to intubate people and hopefully not intubating them if they can avoid it. And we just, because of the, you know, so the changes in elevation, you know, when you get up on the helicopter, we're at 6,000 feet. And then so the helicopter ends up getting up to 10 or 11 or 12,000 feet or whatever. And so, and the length, right? So even our fastest transport time via helicopters, air time of 25 minutes, but you know, that whole process takes a lot longer than that. And so we end up being asked to intubate people by our receiving docs a lot, just so that the crews don't have to deal with that in the helicopter.
Sorry
so I
about
think, yeah,
Sorry about that.
but I think it's reasonable, right? I think it's reasonable because we just don't know. Some, like everybody said on the last round, these people are defervescing so rapidly, and you just don't know. Some of them chug along just fine, you know, with SATs in the high 80s, and then others just fall off the cliff so fast. So I think that my experience is that we've been intubating people probably sooner than maybe y'all would be. And it's been really nice because some of our anesthesia providers have not had much to do because the OR has been completely shut down until just the last few weeks. But so they came through and actually were kind of like our procedure monkeys, basically. They were awesome, and they just would come through, and we'd be seeing a ton of patients, and they would handle the lines and the tubes for us when we didn't have the bandwidth to do that ourselves. So that was really helpful. That they're getting busy again, and we're slowing down enough that we're doing that mostly ourselves now. But
so I mean, the other thing to think about too for transfer is that, you know, right now intubation is one of our higher risk procedures, and we're doing it under boxes and in pappers and sheets and one person in the room and an RT and no one else, right? And so thinking about doing that, if anyone has been in one of those tiny little helicopters, would be very difficult to do safely for the patient or safely for the crew, and would take that helicopter out for a long time. So do you think that you're, now that you guys are opening up the hospital, do you think that that ventilation strategy might change, that intubation strategy, or no?
We've definitely been holding on to people now as inpatients in our hospital. I don't know that we've held on to anybody that has been on the vent for longer than just realizing that they were crashing and need to triage them to a different hospital. I think that we're still kind of just holding on to low acuity people. There have been a few people who we've transitioned upstairs who have needed to be intubated and transitioned to a different hospital. I would say we're all doing our best to try to be as conservative as possible with this, but you know, sometimes you have to just do it based on the weather too, right? If there's a big storm coming in 6 hours or whatever, and you see this person looking, you kind of have to make this guess, are we going to be able to fly in 6 hours or whatever? And so sometimes you will make decisions based on that, or, you know, access to ground crews. If, you know, historically our ground crew situation has been pretty crummy, but for this situation, it actually has been good. But, you know, sometimes the roads are so bad, you know, if there's a big snowstorm or whatever. So there's a lot more than just patients kind of clinical scenario to take into account when we're deciding whether or not we're going to tube somebody, basically.
Yeah, thanks for that. I think just one more question before we let you kind of get mentally and physically prepared for your shift. What advice do you have to, our viewers, our Bafford friends who are in the middle of the country and haven't been hit yet, in terms of preparation, logistics, anything?
Interestingly, my old partners at Evergreen, I was talking to them on the phone kind of right before I got sick and right before we got hit. And their kind of advice was, if it's already there, you just don't know it yet. Start acting like it's there right now. Just do these things and you'll save a lot of lives. And I think that, that advice was it was almost a little bit late because we'd kind of already silently been hit, I think. But I think that if people, it's real and it's out there and it's in rural America too. And granted, our little slice of rural America has a lot more throughput or through traffic than other places. But I think if you're on the interstate or if, whatever, this is going to hit everybody. And it's easy to start just doing smart things to kind of avoid such a steep curve. And so I would just say, just believe that it's there, act like it's there, and then maybe it won't be as bad if you kind of do those things. Get your politicians to, recommend to your politicians to shut down public gatherings, etc. Close schools. I mean, I think our mayor was extremely proactive in that. I think that benefited why we're on the flip side of it now. So I think that it's, a 2-week sacrifice or a 3-week or 4-week sacrifice is worth it to me as far as how much damage this does in the long run.
Yeah, I think we have, a couple things that are good and a couple things that are difficult right now, in that those of us who have not been very hard hit, that our public and our staff are getting a little complacent, which is difficult. Our politicians are wanting to start opening everything back up, and so we're going to be seeing more traffic and more people out and more contact. But the good thing is that I'm hoping that with better testing strategies and more availability of testing that we had a month ago, that hopefully we'll be able to see an uptick in that prevalence quicker than you guys were, New York or Seattle or anything like that. So those are my thoughts. Anything else you want to say, Brock?
No, thanks for including me. I really enjoyed listening to your last your last group meeting.
Yeah, thanks.
Can I ask Brock something?
Of course.
Yeah, so with you being hit in a rural area, do you notice a before and after where I have friends back home in Denver and other places that I talk to, and I ask them, and they think, oh, this is fake, or this is fake news, or we don't really see anything. We kind of think this is a flu or a cold. Is there anything that you can say, to other ER docs, as far as your community's perception of this being a real threat or a real problem?
I mean, so we got hit super hard, like I said, but there still are, and I would say by and large, our community has really been supportive and understanding of this, and kind of because they've seen, everybody knows somebody who's either died or been in the ICU or something like that from it. But I think for the general public, it's really hard when they haven't seen it. It doesn't feel real. But I mean, I think this is hitting everybody. This community here is very fit and active and, not obese. Nobody has diabetes, et cetera, et cetera, et cetera. And we're flying out 20-year-olds that were intubating. We're flying out 40-year-olds that were intubating. I mean, this is hitting, granted, it's hitting the kind of older population and the sick population a little bit more, but for a relatively healthy group of people, we're still having a lot of really sick folks. And so this doesn't just affect people who are ill, because almost nobody here is. I mean, I know that sounds cheesy, but it's like an outdoor community, and this is hitting our nurses, are getting intubated. This is hitting my partners. This is hitting everybody. And to have had coronavirus, and, it was pretty miserable. You don't want to get it. Even if you don't get it that bad, it still sucks. It's really bad. And I don't know that people are going to be able to really believe that until they see somebody that they know or something like that. But if you know, you can send them my email and I'll give them some accounts. But they just need to believe that it's there and it's horrible.
Yeah.
We're glad you're well, Brock. Thanks for sharing that. Am I right in remembering 2 facts about Wood River Valley? One is that 65% of those you were testing were positive, and that it was like at some point a higher per capita rate than Italy. I just want to give some perspective here on what you guys are dealing with.
Yeah, that's right. Right now, I think we're at 37, or the last time I figured it out in the last couple of days, we're 37% of the people we're testing are positive. And yeah, our prevalence rates, when they were still doing it by county, when we could see that, we were higher than everywhere.
Yeah. Well, thanks so much to you and your partners for hitting this head on and doing it, with grace and using your emergency medicine training to the best of your ability. As Caleb was saying earlier, and we'll let him share his thoughts, but he feels sort of like he was meant to be in this moment because of his training and everything that's brought them. And I'm thankful for you guys from Idaho ASAP. We say thank you.
Thanks for including me.
Yeah, for sure. I'm going to scoot over to Hartwell because I know he's got a hard stop as well, and really want to talk a bit about what it's like to be an EM attending suddenly. I think being a medical director of an ER in a state and hospital of the ICU, in a state and a hospital that you are brand new to, and what you're seeing in the ICU and how they've managed to cohort and different sort of ventilation strategies, if you could share and educate us so that we know sort of what is working for your patient population.
Sure, happy to do so. And I would just caveat, this would definitely be in the see one, do one, teach one sort of, disclaimer here. Obviously I'm an ER doc. I haven't been in the ICU in any sort of long-term capacity since residency, which I won't tell you guys how long ago that's been. But yeah, so basically I was asked to be the attending of a overflow ICU at the hospital I'm at. And with that, we had a team of residents. We also had some Navy docs that were deployed to help out at our hospital, which was super helpful. We were managing 13 patients, 12 of whom all had COVID. They were all either intubated or on BiPAP or like very high flow BiPAP. Definitely was a huge learning curve for me. Had to kind of dust off the ICU knowledge and remember how to, adjust events. But it's, to a certain degree, you kind of remember and you kind of get back in it pretty quickly. A couple of strategies we're seeing that have been helpful is intermittent proning. It's been amazing. These people, their ability to oxygen is so poor. You have them on 100%, your PEEP is at 15 and their PaO2 is like maybe 60. And then you prone them for 16 hours and you see their sats go up. That's really been kind of the only thing that we've been able to see that makes a substantive difference in terms of managing their ability to oxygenate. We're trying convalescent plasma. We're doing interleukin-6 inhibitors. We are trying to get her started on a remdesivir trial. I haven't, in terms of the convalescent plasma, it's not like something, no one's just, jumping up and taking their tube out. It's not anything dramatic, but our feeling is it can't hurt. In terms of other stuff we're doing in the ICU, we're anticoagulating everybody, full anticoagulation. Anybody who has COVID and is hypoxic, with the idea that there's some microthrombi going on both in the lungs and other organs. These people have D-dimers of like 25 to 35,000. It's actually quite incredible. So, it's the usual typical ICU care. We're giving them the cocktail of Plaquenil, Zithromax. We're covering them with antibiotics. And then we're also using atorvastatin to try to help reduce inflammation. Usually after we start seeing their inflammatory markers drop, we're monitoring, procalcitonin, SED rate, CRP, and ferritin, which I wasn't aware of for inflammatory markers. Once we start seeing them go down, we also start them on a 5-day course of steroids as well. we are able to extubate some people. Other people, they sort of hang on BiPAP for a few days and they give up. We have to intubate them. We had to intubate someone this morning that was on BiPAP for a couple of days and we thought was hopefully going to turn around. Other people, they're just on the vent. They've been on, I've been there for 3 days and they're just sort of holding steady. Their oxygenation level isn't really getting better, but it's not really getting worse. So we're just trying to support them the best we can, make sure they don't get any super infections, and hopefully let their bodies recover from this.
So tell me a little bit about like logistics. If you're taking care of 12 of 13 patients have this, are you guys like just the whole unit is just assumed to be aerosolized and you guys are just in full PPE like the whole shift, or what are you doing?
I see a variety of strategies, which brings me to a really good point. I think everybody, at least in the unit, they're really, really conscientious about wearing PPE when they go into the patient rooms. But I think once you go to like our sort of dictation rooms or sort of the team room, I think people start taking their masks off and, they relax, they sort of put their guards down. That to me is just super high risk. We're walking through, you have to assume you're walking through a COVID cloud and you're bringing that with you into these rooms. So I just keep my mask on. I wear one N95. I wear it all the time. A lot of people wear respirators. One thing I never anticipated with those big respirators, I'm sure they work great and they're probably more comfortable, but you can't communicate with each other. You can't hear what they're saying. You're trying to present in rounds and you just hear this muffled voice in the corner. You don't know what the guy's talking about. So you have to kind of get closer and then you're like, you're not maintaining distancing. So just something that we didn't really anticipate. I just wear, goggles. I wear a mask, an N95 mask. We have these sort of semi-impermeable onesies that we just wear all day. And then when we go into patient rooms, we put the face shields on. And then we have another impermeable gown we wear on top of our sort of onesie that we wear all day.
Okay. Anything else you want to tell us about the ICU perspective?
I just think it's, I think to a certain degree, everybody's still trying to figure out like what the right treatment is. A lot of sort of anecdotes, everybody does something a little bit differently. So it's hard. We have one intensivist here that if your D-dimer is over a certain amount and you have a little bit of RV strain on your echo, she's giving TPA, and others are not. And so it's kind of hard to kind of figure out what the standard is. We have people on IV albuterol because there's been some studies that it has some theophylline-like effect that can maybe stave off intubation, which, I can't remember the last time I used IV albuterol. Everybody's just trying a little bit something different. I think for the most part, it's just largely supportive therapy. Low tidal volume, sort of high PEEP ventilator settings to try to prevent, barotrauma and to maximize oxygenation. You give them pressors as needed. We generally use Levophed as the pressure of choice. We're not using anything else beyond that. You're trying to keep people euvolemic. I think there's been some debate about whether you keep people dry or not. We don't want to flood them, but euvolemia is sort of the goal. And then just the full dose anticoagulation.
Some of the conversations I've been hearing kind of nationally and kind of MRAP, just had a ventilation management discussion come out just a few days ago, I think, which was really good if nobody's heard it. But in terms of the different phenotypes of the lungs, in terms of kind of an H or an L, can you talk to us a little bit about how you're changing your ventilation strategies for those two subtypes?
Yeah, I saw a little bit of that. I'll be the first to tell you that is way over my head. And so I've been relying on just running some challenging cases. I'll run it by our intensivists upstairs and sort of get their advice. But yeah, so there's the more traditional ARDS picture with low elasticity versus the high elasticity, which is probably more microthrombic, disease that's causing that. For the most part, they've been asking us to sort of maintain the low tidal volume, high PEEP sort of strategy for most of our patients.
Yeah, it's interesting because when we heard from Cameron last week, he was talking a lot about trying to keep the pressures low. And I think it's going to be interesting over the next couple of weeks to figure out where we settle out on this. And I am certainly no ventilation expert, but I think the summary of what I learned on that breaking news MRAP, which I would suggest everyone listen to, is that if you have kind of normal driving pressures, that you probably have a normally compliant lung, and that you can do higher FiO2 and probably lower PEEP to prevent that extra pressure from causing more trauma to the lungs. Whereas if you have a more kind of stiffer lung, then you would do more of an ARDS. But that's just a hammer summary from me listening to it on my way to my night shift last night. So listen to it on your own. Awesome. Thank you, Hartwell. Is there anything else you want to share to us about your experience?
You know, I think my take-home message is that we have to just make sure that we're protecting ourselves and our partners and our colleagues. And, you know, I think we're really good at just being careful when we go into rooms, but boy, we have to be really careful just anytime we're in the hospital, and just really encourage everybody to use universal masking when you're there. Just to kind of share a story, we had in our ER back home, we just heard that 2 nurses were positive, and it was likely a staff to staff, you know, transmission. And so that just sort of hit home for me.
Yeah. Thanks for that. Hey, Tom, can I get your thoughts? Again, you're from Vituity in California, and you guys came in as a group, I think 14, 15. And first of all, on behalf of all of us, thank you guys for doing that. You know, Mike, Caleb, you as well, putting yourselves, you know, out there for our communities and for our partners. And thank you. Can you give me a little bit of a perspective about kind of what it was like sort of emotionally to show up in the midst of all this, what you saw of what our partners were doing when, you know, when you got there, what they were, how fragile they were, how sick they were, what kind of a mess everything seemed, and certainly, you know, share as much or little as you want, but I think this is an important perspective for us to understand.
Sure, thank you. When I first got to the hospital, which was last Thursday afternoon, you know, it was almost surreal. And, you know, this hospital had been all over the news, and things had improved from what it was a few weeks ago when the news cameras were there and they had patients just lined up in the halls. But then you look a little deeper, and if you're not really familiar with hospitals, you would think that this might just be normal. And so they've converted a ton of beds into ICUs. I think they've doubled or tripled their ICU capacity. I think right now they're running 130 ICU beds. And I'm not sure what their baseline is, but it's roughly about half of that. And the particular unit I'm on was a step-down unit, which was a pretty highly functioning step-down unit before COVID. They would take stable vented patients. They would take patients on some drips, but not titratable pressors, etc. And now there's about 35 beds there, and they're still calling it a step-down unit, and it's full on ICU. Patients with, every single room is full of somebody with COVID. Once in a while, there's a mark on a door like, please wear separate gloves when you come in because this patient hasn't tested positive yet. But then, of course, they all test positive. And the patients will be on 3, 4, 5, 6 drips, ranging from 1 to 3 sedatives for their for sedation. They're using, at this hospital, we're using not just norepinephrine, but we're also using vasopressin. And then some of the patients end up also on epinephrine, although that's less common. And so they're super sick. They're all on ventilators. It's also interesting that I think there's 4 different kinds of ventilators, 3 different kinds of BiPAP and CPAP machines, and then 1 kind of high flow nasal oxygen, if you can actually get that one. And so it's even more confusing because you've got all these different ventilators that have various functionality or lack their functionality, and they record things a little bit differently. Some of the transport ventilators, you can't even see waveforms, which makes it a little bit more difficult, or maybe a lot more difficult. So as you're walking down, as you enter, and you're like, wow, this is, you know, really quite remarkable. Now, the other thing that was really remarkable to me is I was fully expecting to see a lot of really tired, kind of not bitter, but burned out and just, you know, short-tempered, miserable doctors. And I haven't seen that, ranging from the attendings, the consultants, to the residents, to the interns. They're all generally they're all not generally, they're all very, very friendly. They're all generally in good moods. I haven't seen a lot of anger outbursts, things that I remember from residency when people get really tired and they would just kind of have a short fuse. I haven't seen that. And I asked them a little bit about this, and they said, well, what else are we going to do? I mean, some of them are bothered by the fact that this hospital is under-resourced. This is classically a hospital that has fewer resources. It's in a lower socioeconomic area. It's a public hospital in New York. And they feel like, the resources aren't there to take care of the patients. And of course, the community is much more vulnerable, probably because they're, a lot of these people were essential workers, but no PPE. So, they were cleaning things or grocery store clerks. And then they live in fairly small dwellings where they can't really socially distance. And, New York's not like Ketchum, Idaho, where it'd be relatively easier to socially distance. And so that whole thing when I first walked in was pretty interesting. And then you walk out at 7 o'clock at night and the entire city, well, at least in Queens, but I think it's the entire city, opens up their windows and they're cheering and clapping for the healthcare providers. So it's really, it's kind of gratifying in that sense. And I feel like a little bit of an imposter because I've only been here for a few days, and yet these people have been really through hell and back in about 6 weeks, and they're still on the road back. But, those were kind of my initial impressions.
When you arrived, were you able to offload some of that? Did it feel like your guys' arrival and presence was able to offload and give some people some physical and emotional relief?
Well, definitely it made their jobs less taxing because there's actually a few of us at our hospital. In Elmhurst, there are 6 doctors from California, 4 from Vituity and 2 from Davis. And this was really kind of a relief mission put together by the governor of California for the purpose of both relieving people in New York and helping our fellow Americans, and also bringing back knowledge to California. And so they were very happy to see us. And of course, they didn't really know we were going to come. We just showed up. I mean, I think I know the administrators knew we were coming, but it hadn't gotten down to the actual doctors taking care of patients. And so, yeah, it's been really helpful for them. And so, for example, like one of the really gratifying moments for me, I don't work in a teaching hospital. I haven't been in a teaching hospital for years. And so there was an intern who, we had to put a central line in because everybody's got lines. So I had to put a central line in, and I said to the intern, do you want to do this? And she goes, really? I'm like, sure, why not? And, it took a long time, which was fine because I had time because, we're like in the role I'm in, it's not minute by minute. I'm not the primary doctor taking care of the patients. I'm really acting as a consultant. And so I could spend a lot of time taking time with her to teach her how to do a line. She said nobody had ever taught her how to do anything like that before in her entire residency. And then she, sent pictures to her mom of me and her after we put the line in. So that was really quite nice. And, so that part experience is kind of nice because I think that the residents are missing some of the usual teaching they get because everybody's just had to put their head down and take care of patients because it was so crazy for so long.
Yeah, for sure. Anything else you want to add about what you've been seeing clinically or from a well-being perspective?
Well, I share some of the insights that Hartwell had in that I think, the people get a little complacent about the PPE and they're pretty good in the rooms. Although even there, sometimes I see people don't have their goggles on or other things on, and it worries me. And I think probably my personal biggest risk is when you're not in the kind of hot zone because there are masks laying around, face shields because you have to reuse your face shield. So where are you going to put it? And so I think that that's probably a pretty significant risk of transmission. And I don't know what the brilliant answer is to fix that other than not have to reuse your face shields and your masks, right? I mean, the reason people have masks laying all over the place is they're reusing them, but you have to reuse them because there aren't enough. So, the solution is going to be a better supply, but we still don't have that adequate supply. Although this particular hospital is better supplied than my hospital where I came from in California. So, given that you're going to reuse those two things, it's okay. And then I think, in addition, the medicine's moving really, really fast, and everybody's got a little bit of a different cookbook. And what I'm really trying to focus on learning for myself and to bring back and just watch what's going on is this decision of when to intubate. So, early on, maybe, I don't know, early March, mid-March, we thought intubate really early because the patients are going to get sick and we want to protect healthcare workers. And then, it became clear that there were all these patients who had actually really compliant lungs, but were super hypoxic. And I don't think we really know why that happens. And those patients don't actually need to be intubated. They can, they do quite well on high flow and CPAP and BiPAP, and it's not yet clear yet. There's not enough data yet to know whether or not we're going to have better outcomes because we haven't intubated those patients. And then they turn into the type, the type H that you were talking about, the low compliance patients, and they to have an ARDS-like picture. And the trick is to figure out when to intubate them, right? Because you don't want to intubate them if they have really good lung function, unless you're pretty sure they're going to have bad lung function. And then you want to actually intubate them before they get the ARDS, because they can start breathing such big tidal volumes in their own that they can do some damage to their lungs. So that's kind of the tricky, the tricky thing right now. And that's what I've been trying to watch and see. We had 2 patients today, very similar. One we intubated, one guy we were planning on intubating, and he had to be moved from where he was to a place where he could be intubated safely in terms of a monitored ICU. And there's none of this box thing. There's none of this negative isolation. It's just put him on the COVID unit with a monitor. So it was more about having, pulse oximetry and everything. And he came upstairs and he looked much better. So we decided to hold off on intubating, but at least now he's in an area where he's more carefully monitored. So if they do have to intubate him, they'll be able to. And there's people there all the time, 24 hours a day, who are capable of intubating.
Yeah, good. Good. Thanks for sharing that. We have about 15 more minutes, and I wanted KK and Mike to share a little bit about what our Emdocs community has done. And then I want to get in with Caleb about some of his clinical strategies and some of the research. And then Mike, I think we wanted to talk a little bit about how to decide how to disposition patients at the end of their hospital course. So KK, why don't you go?
Yeah, I was just so excited the other day. I was literally between night shifts, still in my robe, and it looks like Mike is FaceTiming me. I'm like, oh, but my hair, it's all a mess, and my robe on, and I was like, okay, it's Mike, I have to answer. So I answer, and he's like, look what I've got. And I'm like, oh my God. And he starts showing me, he was almost in tears. I'm sorry to tell on you, Mike, but he was overcome with emotion, good emotion, because he was just filming all of this PPE that people from our group had just so generously just gathered and just sent for him to send out to everybody. And I have to admit, I might have cried a little too, but Mike I was so happy. It totally made my day.
Mike sent me a picture too, and I was like showing everyone, and it was like his hotel room was just like full. I can't imagine what they thought at the hotel.
Wonderful. Go, Mike.
Still there.
Here, and then I've got 4 more boxes today. Y'all, I bet I've received probably 300 Tyvek suits. I've, golly bless it, 95 masks, probably 100 total. And the reusable respirators, we've issued all those out, and to y'all that don't know, I mean, this was all donations. Nobody sold any of this to me. I mean, or they didn't want any money for it. People I've never met, people I've never heard of. Kind of like some of the stalkers in our group that don't ever really speak up.
We like to call them voyeurs.
We love our lurkers. Thank you all.
They're not stalkers. But anyway, I mean, I was just, for somebody who's kind of a cynic anyway, I just thought, wow, this is amazing. And I have been giving them away to anybody that expresses any sort of concern about their safety here on the front lines. We've got, we actually have one of our doctors is over at Coney Island right now working in the emergency department there and with some residents, and he's taken some to them. And I mean, it's anybody, and we're just going to pay it forward. Anybody who feels unsafe anywhere in our group, I will just put it in one of these boxes and ship it right out immediately. So I just want everybody there. I'm going to tell you now, because of our group in the United States, there's no reason for anybody to feel unsafe. We will get you what you need. Okay. Like, just please, if you do not feel safe, contact me and we'll get you what you need one way or the other.
And this all started just because you were vulnerable enough to put yourself in a post and say, listen, I'm running this field hospital and we don't have what we need, and I don't know how to get what we need politically, sort of. So
I could see something else, you know, and so I couldn't, as an organization that I was representing, say, hey, I need donations. I'm not high enough up the food chain to have the purse strings. And so I just, you know, we're in a meeting one night and they're like, well, if we don't get this the next couple of days, we're going to become, you know, mission inoperable, like mission incapable. And so I just came in one night frustrated and just posted on Emdocs, listen, balloon's going up, I need help. And just about 2 days later, I came home from a shift here in the hotel and I had to use the luggage cart to get stuff up to my room. So,
do you have a place to sleep? Or is it all just...
You're giving me another room now. Actually, I'm not even joking. I talked to the desk. I was like, yeah, I got another room on this floor because I can't move around in here. So tomorrow I'm going to go to the room next door, organize it all, and, you know, by size and all that sort of stuff, so I can get a really good feel of what I got here.
Awesome. That's great.
That's awesome.
Thank
you.
I want to come back to you a little bit in a few minutes to talk about kind of how things are now in the field hospital versus, you know, a week and a half ago or whenever it was we talked, and then about disposition. But I really want to talk to Caleb. Caleb threw some clinical pearls and surprises at us about 10 days ago about things that they were working on in his emergency department. Because of that, we've had a lot of connections that I'm sure he'd like to, you know, mention what he can. But I know specifically someone reached out to me through my, you know, my completely different lifestyle medicine company to tell me from Belgium that they were doing something similar to Caleb. And so we connected them. Caleb, can you talk to us, summarize a little bit about what it is that you're finding to work, and then what sort of research opportunities you're facilitating?
Yeah, so I'll begin by saying the people at Coney Island are amazing, doctors, nurses, everybody. And I'm really proud of showing up and seeing their attitude and what they're doing and just the way that they're bringing compassion to people. What's also been very unique about this is we have a unique patient population. When you get hit that hard and, you know, 15 of your patients all have D-dimers that are through the roof, sodium's through the roof, potassium through the roof, glucose through the roof, ferritin levels that are incredibly high, all this stuff, you start seeing patterns. And so I think we're in a position where you could see patterns and trends that you don't see in other places, and you can start figuring out what's going on with this disease. And so the residents have started tracking this. They're getting data. We're trying to use this highly concentrated data set to then disseminate this information to the rest of the United States. So we're trying to figure it out. What I can tell you preliminarily is that it appears that there are at least 3 distinct stages of COVID. That COVID has a stage 1, which is a upper respiratory / GI / asymptomatic. That's going to be very much like a cold. And so people who have this might lose their smell or something, but it doesn't seem to be like a big deal. Then there's a stage 2, which it becomes lower respiratory, it gets into your lungs, and it becomes pneumonia. And at that level, you become hypoxic, you start having issues, and that could kill your older people or your compromised people, right? Just like any pneumonia can. And the crazy part is that we're looking at that as like, oh, that's the middle of the road, that's not too serious, because there's this stage 3 that is just brutal. And that's the one where you have the 24-year-old that's throwing clots everywhere, and you're intubating them and flying them out. You know, what we heard from Brock. This is where it doesn't matter what age you are. Once enough of your lungs have been affected long enough, somehow it's destroying your blood. So I don't know if COVID's starting to infect the red blood cells or what's going on, but you get this picture where you're clotting everywhere. You're having multi-organ failure. You have derangements of sodium and potassium that are through the roof. And I just call it the hyperelectrolyte, hyperglycemic, hypotensive death spiral. And you know, with hypercoagulation thrown on top. And it's a terrible thing. So I think understanding that there's 3 phases of this, And the number of people that go into the stage 3 are roughly the same people who are dying. You know, you think about it. Once you get to stage 3, your odds of dying are incredibly high. And we're sitting at about a 6% death rate right now, 5 to 6%. And I think you have to look at that and say, okay, that's pretty darn high for people who are getting sick. Now, what we have found is that there's different treatments that work at different levels. For example, you get people on montelukast when they're in the stage 1 or the stage 2, and they tell you, this is helping me. I'm noticing a difference. Like, 3 hours ago, I had trouble breathing, and now I am feeling better. Then if you get into a situation though where the person is hypoxic and they are also in distress, montelukast is only going to get you, it's already, it's going to be helpful, but you need to add something else. And that's where we're finding that atropine, 0.4 milligrams IV, is incredibly powerful to get the SATs up again. And, that also intramuscular epinephrine or IV albuterol. Like you mentioned, there's a lot of doctors. We had a Dr. Farrell who came and helped us out from Oregon, and he started using IV albuterol, and it had a very similar effect to the epinephrine IM. Only you're doing it for a longer period of time, and you can titrate a drip with that. And we found that people who get that you can prevent intubation. But then when you get into the death spiral and people are hypotensive, that's when you're going to have people who are SATs are extremely low for long periods of time. Adding something like vasopressin, IM, is what, for some reason it works really well. But intramuscular dose of vasopressin, 10 units, 5 units, will last you for hours and get the blood pressure up. And the nurses will love you for it, because you think about it, these nurses are having a very hard time. You make a patient a 1-to-1 because you're like, well, let's put a fentanyl and a propofol drip on that vented patient. The nurse is not going to be too happy, especially when they're also running pressors on the same patient, and it's just a mess. And that's just one patient out of the 60 or 70 other people that that are in the ER that's now converted into a unit. So I think if you look at it that way, 3 stages, and that you have kind of different ways that you're going to interact, then you'll see that's probably the best way to think about it.
That's great. And a caveat to all of this, of course, is that things change on a day-to-day basis. We don't really understand how all of this is working. And, there's a lot of debate from people saying, it's not evidence-based, and, it's like, of course it's not, right? And right now we're just trying to do the best that we can to save patients. So thank you for summarizing that. So you're those kind of stage 2 patients, are you that are, I'm assuming, high flow or BiPAP, and they're lined up in your ED and you're proning intermittently and all of the other things that we talked about in our panel number 4. Are you anticoagulating those people?
It's 6 o'clock.
And
I'm not anticoagulating those stage 2 people, but I've thought about it. And so I've done some research, and apparently leukotrienes are involved in platelet aggregation. And so we have some people who are looking into that. And I don't know what the heck's going on. All I know is that this is not your typical kind of blood clotting. And if you ask most people that are doing anticoagulation, it doesn't seem to be working. There's multiple types of anticoagulants out there. And I think we need to figure out what the pathophysiology of this coagulation is, because we might just be anticoagulating people to no effect.
Right. It depends. Right. Yeah, that's a great point, because it's like, just like thinning their blood is not the point if it's a certain part of that very complicated clotting cascade that I don't remember.
Exactly. You're 100% right. If we're working on the wrong part of that cascade and the disease is affecting a different part, then it's fruitless, it's pointless, and we're just wasting resources, probably increasing the risk that the patient has. So I think we need to try to figure that out. Kay, you had something you wanted to say?
Yes. Are you all using ECMO at all at your place?
Not in the ER. I know that there's people that are using ECMO upstairs, and there's other places that are using ECMO. But for me, I'm just dealing with, as soon as somebody gets to that level and they get sick enough, we try everything. And if we do a code and they don't make it, then we kind of call it and just go. Just because the volumes were so high, what we had before. But I think one of the things that this has led to is collaboration through Emdocs. So we have people who reached out to us to do research, people here in New York City who said they want to help us out. They want to look into journals. They want to think about it. They want to help us crack the nut. We need to figure out this disease. If we don't figure out what's going on here, we're just shooting in the dark. And I think there's a sentiment out there that this is just some flu that's going to pass through, and then who really cares? This is some disease that,
we're stuck with it.
Yeah, we're stuck with it. And that stage 3 form of the disease is brutal. It's like nothing I've ever seen. And we need to figure that one out, because that's where the mortality is coming from.
Every day you're learning more and more. And the more you can talk to other people who are also learning more and more, we can just build upon that and actually get some data.
Well, exactly. And we can't depend on anybody else but us. If we're the people that are taking care of everyone, we're on the front line. This is what we do as emergency medicine specialists and resuscitationists. We can do that in partnership with our physician colleagues and other specialties. It is up to us. I just want to say thank you to our Emdocs community for all the work that you're doing for that. And of course, you can reach out to me or to KK or to Caleb if you want to get connected to Caleb to figure out how we can figure this out, or find someone who's not in it quite as much to spearhead some of this would be terrific.
Absolutely.
Caleb, do you have anything else about kind of how you see you and your residents and how you guys are doing with your well-being through all this?
Yeah, I think I'm in a fortunate situation in that I came out of, pretty much retirement to help. And you might think, well, hey, you're kind of too young to be retired, but I started a med device company, and it's based off pediatric products. And so I kind of got out of clinical medicine. And then when I heard the call to help out from Governor Cuomo, I said, okay, I'm getting back into this and I'm helping. So I stepped into this, and I was so impressed with what these residents are doing. I come in, and so I work throughout the whole week for my company, and then I do weekends there at Coney Island. And then, also willing to come in if they need me, throughout the week. But one of the things that they have had to really go beyond what you'd expect. Imagine residents who, I don't know how to necessarily say it, but, during a pandemic, work hours and all that kind of stuff blur. That's probably the best way I could say it. And just imagine trying to get your training and be an intern in emergency medicine during this pandemic, and you're being flooded with so many patients. And what about PPE and all that kind of stuff? I mean, what these residents have overcome and done is so admirable. I think they weren't just in a difficult situation. They were probably in the most difficult situation in the world for this. And to have their attendings getting sick, and they're showing up and picking up slack and rising to the occasion to save lives and make sure that the ER is staffed. These are heroes that we really need to recognize. So I am really proud of these guys, but I'd say that they are working really hard. I can pull back a little bit, but they are there. And I think, from a mental health standpoint, we need to, what you guys are doing, coming in from other states and helping out and giving them a break. I mean, if you think about it, these providers are already fatigued to the nth degree. And so, they've been sacrificing, and they've almost gotten used to it. So when somebody else comes in like I do and helps out on the weekend, that allowed the director to go home and be with his wife for the first time in who knows how long. That helped the other guy who worked 21 days straight have a day off. So we really need to think about what we're allowing people to do, when we come in to help. So thank you for doing that, all you guys who've come in from other places, because you don't realize how one day off might be the difference between somebody going down a really dark place, because we reach our limits. There's fatigue, and once you get burned out, it's hard to come back.
Yeah. Caleb, when we're done, could you put a link in the comments to how people can get a volunteer? And then I will also put a link in. As we know, we lost one of our emergency medicine colleagues to suicide this week, and because of this very reason, just know that any one of us that's on this call will pick up the phone and talk to you if you need it. There is also volunteer psychiatry support lines that I will post again in the comments, but if you just search for my name in Emdocs, I've posted it already. Those are docs, our psychiatry partners around the country who are willing to talk to you at any time as well. So just keep that in mind. Support each other. If you see that someone isn't acting like themselves or isn't able to function the way that that they can, please pull them aside, ask them if they need help. We know from talking to our patients that asking someone if they want to commit suicide is not going to make them want to commit suicide, right? So don't be afraid to ask the questions and see what people need. On my lifestyle medicine plug, I also just want to have everyone remember that there are 4 things that you can control. You can control what you put in your mouth. So trying to unprocess your food, eat as much real food as possible so that your brain literally changes the way that it functions when you do that. There's very real data. The second thing is you can control how you move your body. So even if that means you are moving it by stretching or moving it by going up and down the stairs or something, that that amount of exercise and movement also rewires your brain and actually changes your neurotransmitters and how you can think and how you feel. The third thing is that you can control your thoughts. We can't control our circumstances. You can control your thoughts, and what comes out of those thoughts are feelings and actions. So be very clear with yourself that you recognize when you're getting that negative self-talk. Realize that you can ask someone for help for that. I'm willing to do any amount of coaching anybody needs on that. So just reach out to me if that's something you need. The fourth thing is that you can control your inner state. And that's why KK and I moderated that very short meditative training for you guys in Emdocs. Just search for my name again or meditation. It's 3 minutes. All right. This is like a Bafford perfect meditation because it's only 3 minutes. And so look for that. And just, even if you do it once or twice a day, again, we talk some pretty nerdy science in there about why meditation is good for you. So I'll get off my, my wellness box, and thank you, Caleb, for sharing that. Hey, Mike, talk to us a little bit about how your field hospital was. When we talked to you before, you were like, bring me your patients. We are here for you. And now that you have the PPE to do that safely, how is everything going?
So I'm still putting out the same beg, we have some patients, but I truly have an army of doctors and nurses, critical care of all kinds. Tom, we're 3 miles from you. I have to be careful about the amount of, comments I make about the politics involved, but there is no reason why people should be tripping over each other and physicians be tired at Coney Island or, they're at Elmhurst or any of the other, hospitals in that system, because we are in the same system. We take your patients. I've got ventilators, I've got blood gases, I have labs, I've got RTs, I got like 30, 40, 50 RTs. They keep coming in. And they're trying to find places for them. I have 500 beds that are, here. There is no reason why anybody should be tired. Now, we have patients. We get most low acuity patients, mostly patients that have kind of already been through all that. We've intubated a few, that have crashed on us or something like that. Our capabilities are much higher. And so we're finding ourselves as we often do, doing the job that we're handed, right? And so most of the patients that we have in the field hospital now are, what's the best way to put it? They're disposition problems. The hospital just, social work or whatever, got fed up with it and they just moved them to us. And so, so what we are seeing is, if you take the bolus 3 weeks ago that entered this ginormous medical system, right? It initially overwhelmed the ER, moved upstairs, overwhelmed the units, overwhelmed all those. And so now we're at a very unique spot where we have a massive disposition problem. And so, and for KK and other, like, if y'all don't know, like there's a whole like hotel system here where they're taking patients from the hospital, and this gets a little gray, but they discharge them, but they're filling hotels also full of patients that they're not able to send back to shelters or whatever, their homes for whatever reason. And there's kind of a toss up. If they're a little bit higher acuity, we take them, but in the hotels, they're discharged, they're just citizens. And so what this has been showing us, me and my group of huge number of ER doctors here, is like, this just says they had no plan for what was going to happen on the back end. So for weeks and weeks and weeks, we've been talking about proning and all these cool medicines and, you know, how many we're intubating and when to intubate and all that sort of stuff. Me and my group, now we're on the back end with this massive bolus of patients that we need to do something with. And I'm not old enough to have practiced medicine when HIV hit the scenes, but my older colleagues tell me it's very similar. People are scared, the patients are scared, their families won't take them back, their group homes won't take them back, their dialysis centers won't allow them to come, the transporters that take them to dialysis won't let them ride. I mean, I could just go on and on and on. Some of them have major legal issues because they were living in illegal apartments stacked on top of each other. Now their landlords won't let them come back, so they have no rights. And so there's a massive disposition problem. And we are literally out there on the tippy tip of the sword or spear when it comes to what we do with all these people, because like there's just, the book hasn't been written, you know? And so we are now, you know, if y'all know Camilla, she's a big researcher, and she's a powerful woman when it comes to knowing how to put information together really quick. And so she's helping us. We're going to publish our disposition issues and how we're trying to do. So like if a patient is afraid to go home, because the patients are scared, you know, they don't want to go home. Clinically, all the science in the world says it's okay for them to go home, but they don't want to go. And so we start early with the barriers to discharge. What are they afraid of? And so we have patient instruction information. We're sitting down with them each and every day trying to overcome and educate that way. We're going to start sending out our staff to their homes or to their centers or their addiction programs, wherever it is they go, excuse me, where they can't go back, and educate those people. And I'm crossing my fingers. I think today I may have gotten wired in with the right folks to do just like some public service TV and radio commercials, like, hey, you know, kind of quirky. We're the ER doctors from the front line of the COVID crisis. We want to teach you about, you know, when it's safe to go home. And so we're trying to take the stigma back off of that. We're trying to get these people placed because they have nowhere to go. And they're not all homeless. They're not all indigent. There are people, some of them have some resources and they still can't find a place that will take them. So it's really, really unique.
Yeah, thanks for bringing up all those very real logistical issues, and the kind of socio factor of that, just that fear that I'm sure is very palpable. What sort of human resources do you wish that you had, or do you think are really important for us all to be thinking about when we're in your situation? Not your exact situation, but our hospitals when we're trying to do the same thing.
Sure. Yeah, you need a social work team like you've never had before. You need people not that have come from, I mean, it's great that they volunteered to come from out of town, but if they're not in your town, they don't know your systems. They don't know the ins and outs of what the special, I mean, and New York has a gazillion resources. And so you really got to have somebody that knows the system. You also need to beef up your PT and OT. Once this bolus has made it through all this crazy stuff that these other doctors have talked about that they've done to the patients to save their lives, they come to me. They're exhausted, they're worn out, they've been laying in bed, you know, they're 80 years old and they've been laying in bed for 2 weeks. All right. And so because we've been so fat with people, I've got triple board certified people walking patients around the unit. We're just, because we don't have PT. You know, we've got a gazillion other like specialties of different kinds. For some reason on the list of stuff that they hired for, we don't have any therapists of any kind. And so we've got to, you start getting some other effects, you know, like, you know, an 80-year-old who made it through COVID is going to die because they, you know, they can't do their ADLs anymore and that kind of thing. And so you really have got to start planning ahead for those kinds of things, because when the crisis hit, nobody even thought about, thought about that stuff. You know, we're just trying to get oxygen in the patient. Well, y'all did. Yes, ma'am.
Sorry, don't mean to interrupt. Would it be helpful at all if you had maybe PM&R telemedicine kind of docs that could lead some folks into some rehab? Would that be helpful at all?
Yeah, absolutely. Some of the resources that we have had as far as donation have gone is we've got something like 200 iPads. I mean, like we could put an iPad in a patient's hand or in a stand or something like that, or heck, have an aide or one of us go sit with the patient and work through them, you know, through maybe a volunteer PM&R service. Now, again, there's some red tape in politics and who's, you know, don't get me started, but I think I could get that worked out. But that's really a huge need. And it's really funny. I came here thinking I was going to have a laryngoscope in one hand and a box of ET tubes in my pocket. And I'm doing stuff I have never done before, like with a language of things I've never even had to worry about. You know, we lift where we stand, right? And this is where we stand. And so that's what we're doing.
Yeah, it's interesting. The same thing that when you were talking to us last time, when Cameron and I both brought up being in Haiti after the earthquake and like the things that we thought we were going to be doing. And in fact, that's what we were doing. We were like rehabbing, you know, amputations and building a pharmacy and like all these things that you didn't think you'd be doing in a bunch of tents. So KK and I are going to, brainstorm a little bit about how we can at least bring you a collection of people that you can see if you can plug them into your political situation.
We love it. And you other guys at those hospitals, there's help here. If you can find some way to get your patients to us, we'd be happy to clear out some of the cafeterias and the PACU so you can get your hospitals back online and start, you know, getting funds moving through. I believe, and I don't know what you guys think who are practicing here too, I do believe there's going to be some version of a second wave. And so, I mean, you see these curves and these graphs and you see the mayor and the governor get on there and start, I mean, the numbers are, you know, show some improvement. What they don't show is that, well, I guess the three of us here talking, matter of fact, or maybe no, Caleb, I don't know, but we're from out of town. Like the whole system's being propped up by artificially. Right. So like the numbers have changed and the numbers look improved, but there's still patients in the cafeterias and there's still patients in, you know, in every hallway or wherever, and you can't operate as a hospital. Everybody's operating just as a COVID crisis center still.
Yeah. It's all COVID. It's all COVID. And, you know, the moment you start letting other people back, I mean, my thought is this: what happens when we stop having stay at home?
Yeah. Yeah.
It's just gonna start. It's gonna be day one, you know, 28 days later, you know.
Well, I think there's a lot of things that are getting worse, and some of the chronic diseases that are getting worse, and people are staying at home, and they're going to come to us a lot more critical once they finally back.
The non-communicable chronic diseases for sure. I mean, even here in Idaho, where we're like pretty flat, we're not seeing those people come in either. So it's that part of this public health crisis is going to hit all of us regardless of whether we've had our COVID surge or not.
If I could give insight to an area that hasn't been hit yet, it's this: if you're in any way, shape, or form in administration, keep the devil out of the front door. Set up a shelter, set up a field hospital early, make that the COVID center. Okay. Yep. Everybody goes there, they get triaged. If they're sick enough, then they go to the hospital. You don't just bring, it's like the equivalent of a semi full of some caustic chemical turning over on the highway and 100 people getting contaminated. We would all stand in front of the front door of the ER and deny those people access to protect our emergency department, which is what we should have done with this to begin with. So we absolutely crippled the healthcare system here, because now every single space in every hospital here is covered in COVID, whether patients or just the virus itself, and they can't do anything else. They have now crippled themselves.
Yes, I agree with you 100%. And I think a lot of people don't realize this, but if it wasn't for the social distancing, I'm 100% convinced the reason why other parts of the country have not gotten hit as hard as that ski resort where Brock's at, or New York and all that, is because it shut down before it got to you. Because if you would have waited a week or two, you'd be in the same situation as New York. And people think, well, isn't it because New York is stacked on itself? No, that makes it worse. But obviously nobody was stacked on themselves at the ski resort where Brock works, right? And you know, that's something where this disease doesn't need that. It's so contagious. I think people just need to realize we're very fortunate that everything shut down, or else this would be out of hand everywhere. At least that's my opinion.
I think we're going to be having this conversation again in 4 weeks, and it's going to look different, I think, in a lot of places.
I agree with you. I think that maybe not quite 4 weeks, but 6 or 8 weeks, when these places open up, it's going to be a disaster. I'm fortunate. I live in the Bay Area, which had the most aggressive and earliest shelter in place of a place that wasn't hard hit. Now, we did have some very early cases, but that's, I think, what's really saved the area where I live. But I don't think that people are going to continue to abide by the shelter in place, even though just this week in California, or in my counties, my 7-county area, they've extended the shelter in place till the end of May. So even though we have very few cases, they're recognizing the importance of keeping people home.
Yeah, that's great. KK, our Mama Bear, anything you want to say to anybody to kind of summarize this for us?
I am just so thankful for all of you guys. Everybody's just sharing the challenges of this in so many ways that I think it's almost like ad hoc case reports. You know, when we come together, every time I come away from one of these videos, I'm so inspired and thinking of what's the next step. The last one, I thought, oh, there's going to be randomized controlled trials of Montelukast now because they talked about it. And then we come back together a week later, and guess what? There's randomized controlled trials kind of in the works. And so, and now, Mike, with you saying what you need with the rehab, I'm going to get a hold of some people that I know that might be able to do that. I don't know if they can do it or not, but I'm going to ask, and maybe if not my friend, then maybe someone on Emdocs will see this and find the resources that you need. And so I just feel so inspired by all of you guys and what you're doing, and not just in New York, but in other places in the country as well. And I just feel like together we can get through this much better than in isolation. And thank you guys.
Yeah, thank you. I will echo that. Thanks, guys, for taking an hour and a half or so out of your nights. It's late back on the East Coast, and get some rest and be well, and let us know if you need anything. Thanks for taking the time. Bye, everybody.
Good night. Thank you.
Good night.
All right, we are off.